Good morning. Happy Friday, everybody. Welcome to Friday VMR. Hypothetically, most of the time it's an RLR VMR, but occasionally Reza or I cannot make it. And we'll see if Reza is able to make it on this earlier time slot today. But we're really, really thrilled because we have a very seasoned case presenter who I believe is presenting her third case. Is that right? Third or fourth? Fourth! Oh my gosh. Alrighty, fourth case. On VMR. Anmol, I'll hand the mic to you to say hello and maybe reintroduce yourself to those who are joining us more recently.
Hello, everyone. A very, very good morning to all. My name is Anmol Preet Kaur, and I'm an international medical graduate from Punjab, India. I have presented 3 cases on CPS, and this is my fourth one. And I am honestly very grateful for all the love and support I have received from all the CPS team. And I'm forever grateful for that. So thank you so much for these opportunities. Thank you for having me.
It's a pleasure to have you. I would love to just take a minute to get to know you outside of medicine a little bit. What if somebody were to encounter you and you were not in your medical space, either physically or in your head, what do you think they might catch you doing?
I actually love doing bhangra. That is the
Oh, no way.
Punjabi.
Yeah.
Yes. So I do that as a hobby, and I've joined bhangra classes. So I go regularly there. And so if I'm not in, actually daily also, I go to hospital and bhangra class. So out of hospital, you find me in a bhangra class or doing, yes, that's it.
That's amazing. Um, I'm curious, how intense of a physical exertion or a workout is your Bhangra class?
I think it can be what we call in gym as cardio exercise. I think it's like that only. It's amazing. The best part is you have so much positivity in the atmosphere, and
Yeah.
that's my favorite thing of the day.
Amazing. I can imagine that. That sounds so cool. The CP Solvers Academy people are very competitive in some ways and very gentle. I was listening to I was watching a conversation in our WhatsApp group about a Deborah initiated workout initiative where Jas Bajwa is really intensely exercising more than anyone else. But I would imagine that with your Bhangra class, you might actually give him a run for his money. Maybe that competition will play out in the near future. I see Prof. Rez has joined and he's probably wondering what the heck I'm talking about, which is perfect. I love a discombobulated jittery Prof. Rez. Good morning. How are you, good sir?
I am well. What jersey are you wearing?
Can you hear it? Can you see it?
Is it Man United
Oh,
or
I just wanted you to say those words. Yes, correct.
damn the blue threw me off a little bit.
It's a workout training jersey. It's not the actual kit.
Wow. You got the actual kit and
No, I don't have the actual kit.
you're so fancy.
The attending salary is not enough for the actual. Prof. Rez, Anmol is joining us today and is presenting her fourth case.
Wow.
We just learned about the fact that she lives in Punjab, India, and that her favorite thing outside of medicine is to dance Bhangra. And I love the word dance because I think that's what we're slated to do for the rest of the hour on Prof. Rez's last day of a 14-day stretch on service. So you can see he gets more and more casual with every day. You ready to rock and roll, Prof. Rez? All right. You want to take the first Alquat?
No,
Or
you take the first one, please.
okay, you got it. All right, Mo, we're ready whenever you are.
Okay. Who is scribing? Can we just share the screen before we begin?
I'm having difficulty. Gia, can you please share your screen?
Thank you, Tansu.
So actually, I've divided this case into mainly 6 to 7 aliquots. So we'll have plenty of time to listen to all the teaching points and learn so much from you. And so we'll start with the case. The first aliquot includes the chief complaints. That is, the lady presented with intermittent fever for 3 weeks. And I think I should give you an initial part of the HPI as well, if this is okay with you.
Yeah, let's do it.
Okay, so this is the case of an 85-year-old female who came to the outpatient services for regular follow-up of her previous hospital admissions, which were for UTI and osteoporosis. Now, she was found to have complaints of intermittent fever for 3 weeks, accompanied by generalized weakness and reduced oral intake. The fever was low grade, on and off in these 3 weeks, documented around 100 degree Fahrenheit or 37.7 degrees Celsius, the highest being 101 degree Fahrenheit or 38.3 degrees Celsius. There were no localizing symptoms, no pain in the abdomen, no loose stools, no burning micturition, no rash, no cough, and no night sweats. In the current course of the hospital, when the patient was admitted, we started her on broad spectrum antibiotics like meropenem and later on with doxycycline as well. But the patient had no response to the antibiotics as well, and the pattern of fever continued in the same way. So there was no joint pain or joint deformities seen. That's the first article.
Oh, very, very intriguing, Anmol. And I think you moved us along quite a lot. And I think it's not too surprising that a subacute fever like this is not met well with success with empiric antibiotics. And I think the goal of just the next minute, since I know you have quite a bit of quite a number of aliquots, is just to reflect on the rarity of a fever that lasts for this long. It's not quite meeting the definition of a fever of unknown origin because we have to match that with two things. First is the duration, 3 weeks, which this person has. But the second is that there has to be a concerted effort to try to find the localization of this fever. So it's not quite meeting fever of unknown origin, but the truth is that most patients with a fever never have their fever last as long as 3 weeks for one of two reasons. The first is that their infectious syndrome, often viral in nature, self-terminates well before 3 weeks. And the second is that their syndrome, of which inflammation or fever is a prominent part, is often too serious and too ill for the patient to be able to survive 3 weeks without earlier intervention. So this patient has bypassed those two rules, and we can confidently say that her fever is unlikely to be of viral origin unless she's immunosuppressed, and her infection is unlikely to be an open, uncontained pyogenic bacterial infection because of the duration. And so when you realize that that her fever is unlikely to be an uncontained pyogenic bacterial infection, you realize that the success of broad spectrum antibiotics is unlikely to be present. So you may be a little bit wondering what I mean by contained versus uncontained pyogenic bacterial infection, because it's very plausible that a contained pyogenic bacterial infection, such as a visceral abscess, possibly in her kidney as a consequence of her prior UTIs, is a very important cause of a fever that lasts this long. It's contained, meaning that it's hidden, both limiting its ability to obviously declare itself in terms of localization, or be penetrated by antibiotics. So I think the progress you can make here is to say, I have a subacute inflammatory syndrome not responsive to empiric antibiotics. And the question is, are the empiric antibiotics enough to say that this syndrome is not infectious? And the answer is no. We've certainly moved towards non-infectious causes. However, the lack of response to these antibiotics may simply mean that they're not getting to the right place, and that she has pus contained somewhere, either macroscopically in the form of an abscess, or microscopically in ways that we can talk about later. So those would be my initial reflections. I'm curious, Professor, what you have to add.
Nada, my friend. How do we add to brilliance?
Oh, Prof. Rez, don't make me blush so early. It's much more obvious with the morning pallor. Well, tell us more, please.
Okay. So as I said that the patient had previous admissions. So if we talk about that, she had multiple hospital admissions this year, the latest being just 2 weeks back, with similar complaints of intermittent fever and raised inflammatory markers, along with urinary incontinence, loose stools, and vomiting. It was diagnosed as a case of probable UTI along with acute gastroenteritis, as she had marginally increased pus cells in the urine at that time. But the urine culture was negative. And before that, also, she had 2 other admissions for UTI a few months back, for which the urine culture was positive for Klebsiella. Okay, so talking about the past medical history, she has diabetes mellitus type 2, which is now well controlled. She has hypertension, and she has osteoporosis with L3 vertebra fracture. And it was diagnosed as, given her age and her calcium levels were as low as 6.5 in her first admission. So a DEXA scan was done, and the T-score was minus 3.8. So that's how osteoporosis was diagnosed. And the fourth thing she has is chronic hyponatremia, which was refractory to her oral salt intake. And in the current medications, we have a tablet glimepiride 0.5 mg for diabetes, tablet amlodipine 2.5 mg, and she also takes capsule D3 60,000 international units once a week, along with another vitamin D and calcium supplement. And she also takes tablet tolvaptan 15 mg, which was given symptomatically for her hyponatremia, which was provisionally diagnosed as SIADH, most likely due to her hypotonic and euvolemic hyponatremia, and also in part can be due to her primary polydipsia due to psychosis, for which she was given a tablet risperidone as well, 0.25 mg at night, because of her delirium in previous admissions. And she has no known family history, and there are no known allergies. Regarding the social history, she has no history of any recent travels, and the patient lives in a suburban area in South Asia, that is in India. She does not drink alcohol and is a non-smoker, and there is no known animal exposure as well. So this was about the second aliquot.
Well, first of all, I love your background and I love your presentation. It's very, very nice. Can I just ask, how low was her sodium on those prior hospitalizations?
Okay, so in her prior hospital admissions, it reached as low as 125, around 125. This time it was normal because she was taking tolvaptan. At that time, it was 120 to 125. That ranges were there.
Very, very helpful. So I think at this juncture, we're still trying to identify the problem. And if you asked us where we would put the main problem, which one would be the main one we focus on, it would be the fever and it would be the inflammation. Then we're looking at these other findings to see if they're clues to whatever is driving this inflammation. And as Rabih mentioned, as time passes and the fever persists, you start getting away from your common infections. You're open to your unusual pathogens that are bacterial, like mycobacterial infections, fungal infections. But quite frankly, as you get further and further along this journey, all of a sudden, you look at her age, you say 85, you start being worried for autoimmune processes and malignancies. It is true that many of the autoimmune processes may happen younger age, middle age, but there are some, like giant cell arteritis, that the risk factor increases as you age. In fact, you'll never diagnose GCA in someone younger than 50. So it's going to be really important to know if she's had cross-sectional imaging of the chest, abdomen, and pelvis. And I probably wouldn't say fever of unknown origin until we have cross-sectional imaging, because like Robbie mentioned, you might find an abscess or something you weren't expecting. Now we have this hyponatremia. We do know that medications like risperidone and antipsychotics are linked to SIADH, but it seems like our hyponatremia preceded the administration of this medication. And the way you can tease out psychogenic polydipsia or acute water intoxication syndrome from SIADH is actually pretty simple. All you need is a urine osmolality, assuming you have good kidney function, because the urine osmolality is going to be extremely low in someone with psychogenic polydipsia, but it's going to actually be elevated in someone with SIADH. Why is that the case? Because someone who's just drinking a lot of water, they have totally intact kidney. And therefore, what will the kidney do if you dilute your serum? It's going to pee out a dilute urine. But what happens if you have inappropriate antidiuretic hormone? It's going to retain water and you're going to actually concentrate the urine. So this is one of those cases where it gets messy because the patient keeps coming to the hospital, they keep getting antibiotics. So it's hard to know what disorders we're causing as the providers and what disorders is part of the primary process. That's where you got to map out, when was that antipsychotic given? What was the hyponatremia? What was the urine sodium? What was the urine osm? So if the urine osm was greater than 200, the urine sodium was elevated, then you can say it's one of a few causes, and one of them is SIADH. But you got to be careful because you have to make sure the patient doesn't have hypothyroidism, doesn't have adrenal insufficiency. And I'll say this too, it's probable that her hyponatremia is multifactorial. There might be a component of hypovolemia from this inflammation and decreased oral intake. There might be a component of psychogenic polydipsia, and there might be a component of SIADH. But quite frankly, it's easy to rule out psychogenic polydipsia. All you need is a urine osm. And so if that is negative, the kidney function is good, the urine sodium is up, the urine osm is up, all you need is a uric acid. And if that's less than 4, you've diagnosed SIADH. Because with SIADH, you get volume expansion, you get increased filtration of uric acid through the glomeruli, you get increased excretion of uric acid, so you get a low serum uric acid. Then SIADH is just a proximal diagnosis. You got to look for a terminal diagnosis. What's driving the SIADH? Most often, it's nausea, vomiting, pain, post-surgical, or a medication like antipsychotic, but you have to be open again to malignancies. But the issue I have with malignancies is that solid cancers that cause SIADH, they don't often cause this degree of fever. Fever with cancer is usually liquid cancers like lymphomas. Then you look at her calcium and you're like, okay, the calcium is 6.5. That's quite low. What's her albumin? And then you read a Journal of Hospital Medical article, a Journal of Hospital Medicine article of things we do for no reason where we correct the calcium for the albumin. They're like, if you're concerned for calcium deficit, just check an ionized calcium. So we need to know what her albumin is. And then we have to ask why. Why is her calcium low? This is where a parathyroid hormone is really helpful. Whether you have hypercalcemia or hypocalcemia, the first step is a PTH. The vitamin D will be really helpful. If the vitamin D was very low, that could explain the hypocalcemia. But then we got to ask, pourquoi? Why is the vitamin D low? Is there an issue with absorption? Is she not getting sun, et cetera? So you can see how we can keep asking these questions. Why? And even osteoporosis. She's 85. She has every right to osteoporosis. But the calcium, the sodium, there's more going on here. And before I make any more progress and incorporate these findings into her fever, we first need to see these values. And I think once you give us the labs, we'll be able to be more clear as to what's driving the various problems. But what I'll just say is 85-year-old with fever going on this long, I'm already thinking, do I need a temporal artery biopsy? Robbie, anything to, I just taught, but it's hard to make significant progress, I think, until we see the data.
My favorite line was, "It's hard to know what's happening to the patient and what we're doing," and I think that is so telling and an impossible outcome of complicated cases, and you'll never ever be able to eliminate that problem. And I just love that formulation, and we'll have to see what goes into which bucket, the disease or as a consequence of impaired treatment. I absolutely love that line.
I thought you were going to say 2 hours later. Rumor has it Reza is still discussing the past medical book.
Brevity is not your middle name, no, but it's not mine either. All right, Anmol, tell us more.
Okay, so that was a really thorough, detailed explanation. The next aliquot will mainly include the vitals and the physical examination. At the time of presentation, blood pressure was 100/70. Heart rate was 82. Respiratory rate was 18. Saturation was 98% on room air. And the patient was afebrile at the time of presentation. The general appearance of the patient is that she was conscious and oriented to time, place, and person. Regarding the HEENT, the pupils were normal, bilaterally equal in size and reacting. There was no jugular venous distension, no evidence of icterus with normal conjunctiva, and palpable cervical lymph nodes were present on the right side in the posterior triangle. Cardiovascular examination, pulmonary, abdominal were unremarkable, and neuro GCS was E4, V5, M6 at the time of presentation. Regarding the extremities, no rheumatoid arthritis type joint deformities were seen. So that's about the physical examination.
Amazing, a really, really informative exam. And I'll say that I think that there's a couple of things I'm noticing. First is just how incredible Tansu's scribing skills have become. I'm not sure if you saw how complicated that initial two aliquots were. Tansu focused, turned her video off, and just went at it. And it's amazing to see how you can organize such a complex case, Tansu. Is really cool. In terms of the exam, I think it's a great example to show you how something very, very subtle may be incredibly powerful here. And if you had not realized the importance of a good neck exam, here's what could have happened. You could have not palpated the posterior cervical triangle, not seen this lymphadenopathy, and be completely lost as to what's going on, when now I think you found a profound clue. Now, why is this a profound clue? It's because of an anatomical explanation. Right now, all you can really say is this person has localized lymphadenopathy. Localized lymphadenopathy often reflects a localized problem, such as a local infection. And a great example of that is inguinal lymphadenopathy in the face of cellulitis, or anterior cervical lymphadenopathy in the face of group A strep infection. So here, the question is this truly localized lymphadenopathy, or is this the tip of the iceberg? And what helps you realize that is that the drainage pattern of the posterior cervical lymph nodes is very, very unusual for it to reflect a localized infection. An infection that's draining into the posterior cervical lymph nodes is often a deep space retropharyngeal infection, which would not be as subtle so as the patient would lack any symptoms referable to that area. So the probability that this posterior cervical triangle lymphadenopathy represents local lymphadenopathy as a result of a local infection is super low, because a local infection draining to that node would be somewhere in a very devastating, concerning place. It is possible, though, that this patient has a local tumor in that area, and there are some local tumors notorious for causing a fever of unknown origin, namely EBV-driven nasopharyngeal cancer. So I think the core question in this case has become, in this subacute inflammatory syndrome characterized by many subtle but important lab abnormalities and findings in the background, is this posterior cervical lymphadenopathy localized? And if the answer is yes, then it becomes very likely that we're probably going to find an underlying tumor. because an infection would not be as subtle as it is in this case. If we later learn that this cervical lymphadenopathy is the tip of the iceberg, then it becomes a more simple problem of what causes disseminated lymphadenopathy in a subacute febrile circumstance. And that is a problem that has a pathway to solve. So right now, we don't know what train to hop on. Is this a subacute inflammatory syndrome with localized lymphadenopathy? Or is this subacute inflammatory syndrome with surface lymphadenopathy being cervical, but visceral lymphadenopathy being present? And yeah, I'll leave it at that and pass the mic to Prof. Rez for any thoughts or anything that caught your eye.
Tip of the iceberg, baby. I love that.
All right, and well, tell us more, please.
Okay, so we'll talk about the basic labs. HB was 11.3, MCV was 72, TLC was 10,500, that was increased with the neutrophilic predominance. Neutrophils being 56% and lymphocytes being 39%. But the absolute lymphocyte count was high. Platelets were 5,38,000, that is high. Sodium was 134. Potassium 4.06. Chloride was 90. Calcium is 9.3. Phosphorus 3.7. And the sugar at the time of presentation is 113. Talking about the inflammatory markers, procalcitonin is high at 0.2. ESR is high at 65. CRP is again high at 172.5. Serum uric acid is 3.1. BUN is 8. Creatinine is 0.97. LDH is 211. That is normal. Ammonia is elevated at 63.1, and urine routine at the time of presentation was normal except for trace proteinuria. Total serum bilirubin is normal at 0.46. AST is high at 155. ALT is high at 124. And serum total protein is 8.3. GGT is 65. And ALK-Phos is 222. And total cholesterol level is normal. That was about the basic labs.
Thank you so much, Amal. Just to clarify, the total white blood cell count was 11,000. Is that right?
Yes, 10,500, which actually
10,000.
got high during the course of the hospital as well. They reached 22,000.
Okay, perfect.
Yes.
Maybe what I'll do is just focus on the CBC and then pass the mic to Robbie to discuss the rest of the laboratory findings. You know, I think that the complete blood count is really helpful. So far, what do we have? Intermittent fevers, cervical lymphadenopathy, and a lymphocytosis. And I say lymphocytosis because that's unusual when we're typically dealing with inflammatory processes. Oftentimes we see a neutrophilia because you get demargination of these mature neutrophils from the endothelium. So whenever you see a lymphocytosis, there's a few diagnoses you must consider, and each of these diagnoses also cause lymphadenopathy.
Am I interrupting? Oh, Prof. Rez, I just wanted to clarify. Is it neutrophil? I thought I heard neutrophil predominant. Is it neutrophil or lymphocytes?
Oh,
okay. Yes, the neutrophils were, as comparatively, neutrophils were at 56% and lymphocytes were 39%. But if we talk about the absolute lymphocyte count, then absolute lymphocyte count was high.
Oh, I'm sorry. I'm sorry to interrupt you, but I didn't realize that. Yeah, so it's neutrophil predominant, but the lymphocytes are higher than normal, is what you're saying. Is that right?
Yeah, that's really helpful. Thank you, Robbie. I think that like if it's just 50%, 56% neutrophils, yeah, predominant. But for me, like a neutrophilia, usually we see it 80%, or above. I don't know. I think it's worth considering the lymphocytosis, but thank you for not letting me fail if the lymphocyte count was like 20%, which oftentimes then it would really be irrelevant. But I think it's worth just thinking about the causes of lymphocytosis. And when you do that, what gets prioritized is really infectious mononucleosis. Now, infectious mononucleosis most often is EBV related, but it would be really hard to imagine someone at the age of 85 just presenting with EBV mono. And then the cousins, including HIV and CMV, you have to send an HIV. Like, age alone should not dissuade you from considering HIV as a diagnosis. And we've made it. We made that diagnosis before in 80-year-olds and such. And then there's toxo that can also cause a lymphocytosis. Basically, if you say fevers, fatigue, lymphadenopathy, lymphocytosis, I think it's a good operating frame to say that this is consistent with infectious mononucleosis. Now, what's really helpful here, and I think will allow us to make even more progress, is getting a peripheral blood smear, because it's not only the absolute lymphocyte count, but they look unusual. These are atypical lymphocytes. So in mono, you may have normal lymphocyte count, but they appear abnormal on the peripheral blood smear. Things that can mimic infectious mononucleosis include stuff like lymphoma. I think lymphoma has to be considered given the fever, the lymphadenopathy, but like the platelet count being high would be unusual. So we'd have to flex that illness script if this were lymphoma. And then drug-induced hypersensitivity syndrome, also known as DRESS. A portion of those patients actually don't have eosinophilia. They present with fevers, they have abnormal liver chemistry tests, and they may have a lymphocytosis. They often have a rash. So the lack of rash, the lack of eosinophilia, I think makes that less likely. So I'm going to pass the mic to Rabih, but where I am right now is like an elderly person, ongoing fevers, cervical lymphadenopathy, lymphocytosis. And one last thing about those lymphocytosis, it could be monoclonal in nature, and that's when you start thinking about CLL. But CLL can have a Richter's transformation where you do get a lymphoma from that. So it'd be important to look at her prior CBCs and see what her lymphocyte counts were. Because if they were elevated for a long period, then that hypothesis, I think, is worth entertaining. To you, Rabih.
Oh, Prof. Rez, I learned something so powerful in the last alquad, which is just when Anmol said neutrophil predominant, I stopped focusing. And it was just such a cool thing to realize that, like the point you just made, that you should run your lymphocyte differential diagnosis here is so powerful and well noted. It's a really good lesson to upload. I think the only other data that's in red, courtesy of all the other data we presented, is the liver enzymes here. And I think that in many instances, you would probably gloss over these liver enzymes in real life because just like the kidney is allowed to have a little bit of an injury from ATN and a systemic infection, the liver has its ATN equivalent too. And if you were trying to draw out things in scale, 3 weeks of fever with an AST only twice the upper limit of normal is such that it's unlikely to be signal unless you find other corroborating data like liver like imaging abnormalities. But I think it's really important to make sure every single time you have liver enzymes to ask yourself, do I really believe they're in the liver? And for me, the threshold to get a CK has been crossed because the patient has an AST predominant liver injury. So my take on this would be that so far, I think the localization of this disease process seems to be in the lymph nodes, and the question hasn't changed about where this disease is. Is the cervical lymph node the tip of the iceberg or the entirety of the case? And Prof. Rez's reflection on the nature of the disease, be it infectious mono or malignant lymphomatous disease, that is a profound one. And I think the liver enzymes can be a false localization because of their mild nature, but the AST predominance should prompt a CPK to make sure that this subtle muscle syndrome isn't part of this disease process. All right, and we'll tell us more.
Okay. So moving over to the specific labs, Leptospira IgM was positive at 11.61. Thyroid function tests were done, and T3 was low at 48. T4 and TSH were normal. Viral markers HIV, Hep B, Hep C were done, and the patient was non-reactive. Urine culture was done, and it came out to be negative. Vidal test for typhoid was performed, which had normal titers. Monto test or tuberculin skin test was done for, and it showed less than 10 mm in duration and was concluded as negative. Scrub typhus IgM was negative as well. Rheumatoid factor was positive, and ANA was positive at 4+. Complement levels were done. C4 was mildly high at 54.1, and C3 was normal at 149. That's about the specific labs.
Oh, amazing. Oh, the good thing is about leptospirosis is I've never seen it in real life, but courtesy of Prof. Rez, I had practice thinking through a case in my intern year, and then have thought about it many times on VMR. And this case presentation is less compatible with it because leptospirosis is an acutely deadly disease, not one that prompts a subacute inflammatory syndrome. And it goes to show you that antibody testing is inherently noisy and has to be matched with the clinical syndrome. So here, I think I would probably not make too much value of the leptospirosis positivity. Equally important is not to make too much of the TB skin negativity. We know that this patient's PPD or tuberculin skin test is negative. And the differential diagnosis for that is two things. The first is the patient does not have latent TB, or two, the patient does not have a strong enough immune system to tell us that they have latent TB. And so the question in this patient is, are they negative because they're anergic because they don't have a robust skin response? And that's the value of the interferon gamma release assay, which studies both the response to TB antigens, but also response to candidal antigens. And that tells you, that can give you some insight into the status of the patient's immune system. So we're ignoring a positive with the leptospira. We're not ignoring a negative with the negative tuberculin skin test, and then we're going to come back to ignore another positive, and that is an ANA. While many autoimmune diseases can occur in older adults, the ANA positive diseases, namely lupus, scleroderma, Sjogren's, and mixed connective tissue disease, are almost exclusively disease of young to middle-aged adults. The notion that the ANA positive is a false one is further reinforced by the fact that the complements are not low. So what is Anmol, I think, doing here is showing us the complexity of interpretation of diagnostic testing and the headache that they can give you. And so I'm pretending like I'm saying all these things with confidence, but you need to be able to make progress in this case. So could there be a signal here that we overlooked? Yes, but only in retrospect when we get more data, namely the imaging, to help us figure out what I think is still the core question in this case. The exam is more powerful than anything you've given us so far. He has palpable posterior cervical lymphadenopathy. Everything else here is decoration. That's the core piece. And that's the part that I'm really hoping to understand. And then we will reanalyze all this data when that question has been answered. And so I love the teaching that you're getting out on. Well, you're really stretching my thinking. I'm curious, Prof. Rez, any other observations you made with this data?
Not I was just laughing. Sometimes the terms you use, the rest of it is just a decoration. I love it, man.
All right, and so what is it going to be? Decoration or the core tree? Let's see what you have.
Let's see. Okay, so now we'll talk about the imaging. I would like to share my screen for one of the imaging of chest X-ray if I'm able to, because I've never done that. And I don't know.
One moment. I'll just make you co-host. I think I forgot to do that. No, you should be able to.
I'm already, yes. So I think I'll be able to share it. Please let me know if it's visible.
Looks great.
So this is the chest X-ray for this patient. Anything which you have to say? Maybe?
Yeah, I'll tackle this. It's abnormal. We'll start there. If you look at the right hemithorax, there's this strong white density that it's more than just atelectasis, because oftentimes when we have like whiteness, we say maybe a portion of the lung is collapsed, and it's almost like obeying a part or a lobe of the lung. So with this finding, you need a CT scan if you're able to at your center, or a POCUS, because you can see that there's blunting on the right side. So there's pathology in that right lung. And if we think about this patient, they had no findings of dyspnea, cough. Everything was just non-specific diarrhea and urinary incontinence. But the only clue we had was lymphadenopathy and fever. And this is the importance of imaging. Like, you can't diagnose FUO unless you get cross-sectional imaging of the chest, abdomen, and pelvis in a place where you can actually obtain those. Some places you can't, so it's different, and you have to apply different standards. So looking elsewhere, I'm sure if we get the CAT scan, we might find something in the other lung, but I'm really curious almost to see the CAT scan.
Okay, so I just have the imaging for the chest X-ray, but rest I have the details, written details. So this patient was actually misdiagnosed earlier as a case of dextrocardia, but that was just because of misinformation. But later on, it was realized that it is cardiomegaly, and in this case, and probably we can also see or appreciate the water bottle configuration here. And so I'll just stop the screen share. Okay. So the chest X-ray AP view was done, and cardiomegaly was noted. 2D echo was also done, and mild pericardial effusion was noted with an ejection fraction of 45%. Then, yes, as you said, chest CT with contrast was done, and moderate to severe pericardial effusion was noted with pericardial thickening, suggestive of pericarditis. And mild bilateral pleural effusion was also noted. Then ground glass opacities were seen in the right lower lobe and posterior segment of right upper lobe. Atelectatic bands with small area of consolidation seen in the superior segment of the right lower lobe. And enlarged inhomogeneously enhancing pretracheal lymph nodes were seen measuring approximately 12 mm. So this was about the imaging.
Yeah, I think that Anmol, you're showing us that ultimately when a disease is localizing into a specific concrete space, namely the cervical lymph nodes, it's very likely that you'll find the evidence of that disease coalescing in other places. And I think that what you've now essentially found is that this patient has a subacute inflammatory syndrome with lymphotrophic features with the cervical lymphadenopathy that is now confidently a disseminated lymphadenopathy problem because you see pretracheal lymph nodes. And the initial focus of the disease is that it also involves the pericardium. And I think that problem representation of a subacute inflammatory syndrome characterized by three things: disseminated lymphadenopathy, lymphocytosis, relative lymphocytosis, and a inflammatory pericardial effusion allows you to make much more progress on the core issue at hand. And so, Prophet, since you just analyzed the X-ray, I'll pass the mic to you to see where you're at. I just wanted to see how this make the point that the problem is so much more clear now, with the only obvious gap being we don't know what is happening below the diaphragm. And I think that might be an important aspect of this case, but we've certainly made a lot more progress.
Thank you, Robbie. And I think the important thing here on that X-ray is just knowing that there was something abnormal. And then once you know that something's abnormal, then you often reach for additional data to clarify what that abnormality might be. And if you're ever going to diagnose dextrocardia, I think it's important to try to review the prior imaging to make sure that's the case. And you always have to be cautious in the context of someone with like fevers that are ongoing, where you have to really question the impression of certain findings. I think, Amol, you're really teaching us that there's a lot of data here, and being able to tease out what's signal, what's noise, what to dismiss is critical. I think that, Robbie, for me, like really what my anchor is right now is this pericardial effusion and the thickening of the pericardium. Like that is unusual. I would go back and see, one, if there's any evidence of tamponade physiology on my physical exam. So I would do a pulsus paradoxus. I would re-examine the JVP. And then the echo, I would see if there was any collapse of that RV wall during diastole to suggest tamponade. But if you tell me this is a patient that's outside of the US with pericardial thickening, effusion, a thrombocytosis, lymph node activation, the most common cause is tuberculosis in our infectious bucket. And this patient did have some pulmonary findings. So this would be like extrapulmonary TB if it were that, because I'm trying to think, Robbie, like where am I going to get my diagnostic answer? And of all the data that has been presented so far, what's been most impressive to me is this echocardiogram and this enlarged heart, which is really enlarged pericardial fluid, and the thickening of the pericardium. It is true that it's not just TB that can cause pericardial thickening or pericardial effusion. You can run that list of malignancies that can involve the pericardial space. There's autoimmune processes that can involve the pericardial space. But in this patient, I don't know, Robbie, what do you think? Like for me, TB is something that is very, very concerning, just given where this patient is located, the subacute course, the thrombocytosis, and the lymphadenopathy. Though, at the end of the day, I don't think you can make that diagnosis without getting tissue. And the question is, what tissue? I worry that maybe the lymph nodes may not have, it all depends on the size of these lymph nodes. But of course, we want to go after the safest site. And the problem with pericardiocentesis is oftentimes you don't get an answer unless you do a biopsy of that pericardium to further evaluate. Thoughts?
I completely agree with you. I think when you have a pericardial effusion in the context of a systemic inflammatory disease, it changes the calculus dramatically, because most patients with pericardial effusions, about 70% of them, have no other disease anywhere else, and they're termed idiopathic pericardial effusion. But when the pericardial effusion is occurring in a systemic inflammatory context, the question really is it an infection or a cancer? Of course, it could be an autoimmune disease, but the age of this patient makes that incredibly unlikely. And so what kind of infection? It's TB, and what kind of cancer? Both solid and liquid cancers. So I completely agree with you, Prof. Rez. I think this person either has tuberculosis or has a solid tumor, and the solid origin has not been appreciated because we don't have imaging of the belly, or has a liquid tumor like a lymphoma. But I think that given the prominent, most patients with lymphoma do not have thrombocytosis. Most patients with lymphoma do not have SIADH. And patients with TB have both those features, SIADH and thrombocytosis. And as Anmol warms her hands to give us the next aliquot, a juicy one, I imagine, I'll just emphasize that that when we talked earlier about reanalyzing things, when you get more data, here's one major reanalysis that I'm doing, which is, we heard from Anmol very briefly and casually that this patient gets delirious in the hospital. And yeah, she's 85. But now that you have involvement of, you're thinking about TB and cancer, and you have an older adult who gets confused, especially with TB, and especially if TB is causing SIADH, you have to wonder, could she have tuberculous meningitis? And of course, you can do that calculus by seeing how confused she is now. But the more disseminated this problem is, the more you have to look back and see, wait, Did she have sterile pyuria as a manifestation of TB? Does she have TB meningitis as a manifestation of TB? All those things become really, really important, including whether or not she truly has a compression fracture or whether she has POTS of her vertebral spine. So all these things now have to be reanalyzed because you found that her problem is not what it appeared to be. All right, Anmol, please tell us more. And now I'll warm my hands and
Thank you for teaching me so much. So this is going to be the final aliquot, after which I will reveal the diagnosis in the next one. So we said that the ANA was positive and the reflex ENA profile was done, which was negative. And blood culture were also negative. And regarding that lymphadenopathy, the FNAC right cervical lymph node was done. And the microscopic examination showed epithelioid cell granulomas, suggestive of granulomatous lymphadenitis. And also, pericardial tap was done by the interventional radiologist, and the pericardial fluid was analyzed. It was slightly hazy, pale yellow-colored fluid. Glucose was 44. LDH was 1425. Proteins were 4, that is exudative in nature. Cytology for malignant cells was negative, and presence of inflammatory cells was appreciated. Acid-fast bacilli were not detected on AFB smear of the pericardial fluid. That's it about this aliquot.
I think this is super helpful. And where we are is we have granulomas in the lymph node, and then we have this pericardial fluid analysis. And I will tell you, I did some reading on this recently. The protein, LDH, glucose, all this stuff is not too helpful on the pericardial effusion. What is helpful is the gram stain, the culture, the cytology, and the ADA. And the question becomes, with granulomas, we're right where we were before this aliquot. Is this TB or is this lymphoma? Personally, the lack of AFB does not dissuade us from tuberculosis because it's difficult. Like in the peritoneal space, it's almost like impossible to identify the AFB. You got to do the peritoneal biopsy. And I feel in the pericardial space, like I wouldn't feel comfortable saying this is not TB until you do a pericardial biopsy. The question really I would have, Robbie, for the consultants and like the team, it takes us back to SIDM in 2018. Like, when do you just say, you know what, my pretest is high enough, I'm just going to treat empirically for tuberculosis, as opposed to do and that all has to do with the context of where you are working and your comfort with illness scripts. So it might be worth saying, hey, could a lymphoma or something present like this too? And they'll be like, well, look, the thrombocytosis is unusual, this, that, and even the pericardial effusion, yes, it can happen, but we already know base rate alone, more than 60% of pericardial effusions with systemic inflammation worldwide is due to tuberculosis. So I'd love to pass the mic to Robbie to hear his thoughts.
I have nothing to add, my dear friend, Prof. Rez. That was absolutely superb. Yeah, I agree with everything you said. I just emphasize that a negative TB skin test does not mean the patient does not have TB. And even if this case turns out to be a lymphoma, I would give this, I would honestly give this chance 80% TB, 20% lymphoma. And so if you play it 100 times over, you'll get TB most of the time, and sometimes you'll get lymphoma. And in the instances where it turns out to be a lymphoma or another cancer, you can't say, oh, the TB was negative, so it wasn't TB. That's, I think, the major trap in a case like this.
And Robbie, can I add something? If you think about this PPD test, when we do it in patients who are immunocompromised, what do we say? Like, we have, like, it may be negative because they just don't have the immune system to respond to it. This is an 85-year-old woman. The majority of her bone marrow has been replaced by fat cells. So she may not mount the typical immune response, and this applies to the PPD test, and why she hasn't maybe localized anywhere either.
All righty, the mic is yours, my friend. What did you find?
Okay, so we have the remaining pericardial fluid analysis findings as you were saying. The TLC was done total count 2000 with lymphocytic predominance, showing 90% lymphocytes and 10% neutrophils. And ADA was high at 70.90. And then Gene Expert Plus test was also done, and the report came out after 3 weeks. The AFP culture was positive, which was identified as Mycobacterium tuberculosis complex, and the patient was diagnosed as a case of TB pericarditis.
First of all, I think, you know what I enjoyed most about this, Amol, was really like just watching you present, like your enthusiasm, your excitement. It's like you were just saying like, Reza, Rabih, just shut up and let me keep going. You weren't saying that, but you were just so excited to share this story. So for me, that was the highlight. But I love this case so much because it just reminds us, like, elderly people, you got to be cautious. And then my main takeaway is what Rabih said, is that once you have this diagnosis, going back and reviewing the other elements of this story and asking what might actually be TB related, like in the spine specifically, and what might not be. But we'd love to hear from the mathematician and his take on this.
Oh my gosh, Prof. Rez, if you do that exercise in here, you're like, oh, I know a notorious cause of sterile pyuria, it's TB. I know a notorious cause of inflammatory SIADH, it's TB. And I know a cause of posterior cervical lymphadenopathy, it's TB. It's crazy. It's really, really cool. But I think the hardest part about solving these cases in real life is to know how to interpret the data that's coming your way, and honestly to realize what is decoration and what's core data. And there's so much stuff here. What about the low MCV? Could she be having iron deficiency? Is that a GI bleed? Did she have liver involvement? Does she have leptospirosis? Is she hypothyroid? Does her ANA positivity mean anything? You have, it's really, really hard to filter signal from noise. And that's what you get better at by coming here and practicing these cases. And ultimately, if you were streamlined in your thinking and got a lot of practice, you would be like, subacute inflammation, cervical lymphadenopathy, I don't need to know any single lab test. I want to know what the imaging is like. Oh, subacute lymphadenopathy, now inflammatory pericardial effusion. That's it. And the rest of the data, you don't even need to know. Because if you say, I found lymphadenopathy in a pericardial effusion in an 85-year-old woman who resides in suburban India, who cares what the AST is? She needs analysis for TB. So I think for me, this case is a great practice in realizing that the most efficient pathway to an answer often involves minimizing your test ordering and focusing it and doing it in a target manner so you don't get distracted by a negative TB skin test or a positive ANA. Great illustration of that. I'm curious, Anmol, how it was like taking care of this patient, what lesson you learned, and then importantly, what happened to her with treatment.
Okay, so this patient, as we can see, did not have any classic symptoms of pericarditis. And I read about it, the chest pain was not present. And it is present in acute infectious pericarditis, but it is usually absent in slowly developing TB pericarditis. And so it was actually a very interesting case for me. I got to learn so much. And this lady who had unresolving fever, unresolving inflammatory markers, which was initially attributed as UTI, and it was unresponsive to antibiotics. So we could actually say that this was a case of a fever of unknown origin. And I agree with your remarks that we cannot say a fever of unknown origin unless we have actually evaluated the patient. And I think FUO and idiopathic are just terms. If we actually go and find out the cause, the term changes. So this patient actually required the evaluation only. And so the main thing in this patient was the cervical lymphadenopathy, which actually guided the entire diagnosis. And we went with the imaging as well. And as I said, chest x-ray, it was misdiagnosed initially as dextrocardia, but later on we realized on chest CT and echo that it was pericardial effusion. So, and if we see the chest x-ray closely, it was kind of a water bottle configuration on the chest x-ray as well. And talking about the leptospira, it could be false positive as well, or it could be a mild infection which got treated with the empiric antibiotics we started, like doxycycline. So maybe it just got treated, but was not the main diagnosis for this patient having intermittent fevers. There was something else. And FNAC, so basically lymphadenopathy came and FNAC was done. It came out to be granulomatous lymphadenitis. And as you said, in India, in these endemic areas, we have to think about starting empiric ATT. But here in this case, the thing was RF was positive and ENA was positive. So it could be autoimmune pericarditis as well. So we had to be doubly sure that what is causing this pericarditis. So pericardial tap had to be done, and it actually came out to be exudative and lymphocytic rich, high ADA, which is actually the case in TB. And direct smear examination is rarely positive. So that's the case. And so this patient was basically started on empiric ATT because we knew that gene expert test would like come after 3 weeks. And we had to start with the treatment, otherwise she would have developed constrictive pericarditis, and that would not have been good. And so we started her with empiric ATT, and interestingly enough, the inflammatory markers came down and the fever episodes reduced. So it was another assurance that yes, we have diagnosed it correctly. And after that, then the positive results came after 3 weeks. And with this patient, actually, she had little side effects as hepatitis after the ATT. So she had to be changed to modified ATT as well. Levofloxacin was added. And yes, this was pretty much the case, I think.
Oh, I love your enthusiasm and your passion for medicine and the attention to detail that you have for all these things. It's palpable. It's really, really cool. And we're very, very grateful for case number 4 and hopeful that it's the first of many. Thank you so much, Anmol. And I can't think of anyone more fitting to do the teaching points today, because my first introduction to TB and its very devastating effects on the mediastinum and the pericardium was through GS case a long time ago. So I'll pass the phone to you, the mic to you, Gia, to do the teaching points.
Yeah, thank you for this beautiful case and beautiful discussion. And actually, this case really reminds my presentation in a Friday ILR. And I remember my case was also a TB involved with pericardial infections, but we didn't find the pathogen, and so we did a trial of treatment, and the patient had a response to that. So I love this case. Yeah. So I will share what I had learned today. So today we got an 85-year-old female. Came with 3 weeks of fever, and firstly we discussed about what could be the cause of a subacute fever on response to antibiotics. At that point, we could not conclude that it is not infectious etiology, because we have to think about whether the antibiotics come to the right place, is there any possible abscess in the patient's body, and also Dr. Rabih lead us to go through the 2 rules to diagnose the fever of unknown origin. And then we got the patient had a history of hyponatremia, and Dr. Reza help us to think about how to think the hyponatremia. In this case, the patient had infection, UTI, and diarrhea, received antibodies, and so it is kind of difficult to know when the hyponatremia happened and when all this infection and treatment, the time costs of all these things. So the urine osmo and the urine test is very important to make the differentiations. And then in the physical examination, we got a very important clue that this patient had localized lymphadenopathy, and then we have to think about, is it a real localized cause, or is it just like the tip of the iceberg? The lymphadenopathy was caused by systemic etiology, and then from the labs, Dr. lead us to discuss the course of lymphocytosis. Like the common cause infection of any virus, EBV, HIV, CMV, and malignancy like lymphoma, and also the Draft syndrome. And then I think the interesting case in this interesting part in this case is about the labs. We should really know what is like signal and what is the noise. In this case, the patient had the leptospiral IgM positive, but Dr. Rabih also pointed it is a very like confounding finding, and the leptospirosis is really a very acute process. And then we got the negative TST, and we should think about, is it really negative, or is it related to the patient's immune system, especially the patient is an old lady. And then we got the positive ANA. We also should think about, is it like have any function can help us in this case. And finally, we got a very important clue from the imaging that this patient had pericardial effusion. So then the picture, the whole picture become more clear to us. Our focus was on the pericardial effusion and disseminated lymphadenopathy, and then plus the systemic inflammatory process. And we did broad discuss about whether it could be the infection or cancer or autoimmune disease. And considering this picture, in this case, the patient also had the thrombocytosis, ADH, and also alternate mental status during her first hospitalization. And then we tend to make it like the TB is more likely. And although the pericardial fluid tests revealed negative AFB initially, but we really need to think about it. Is it a true one? How it can make our make any changes in our thinking and in our treatment? And so finally, the patient was very lucky to find the positive pathogen evidence and have the final diagnosis of TV pericarditis. And I think my takeaway from this case is just as Dr. Rabih and Reza said, how to interpret the clinical and the investigation findings. Is it true a signal or just a noise? So that's what I had today. Thank you so much.
And all your teaching is pure signal with zero noise. That was an excellent job. Thank you so much, Gia. Thank you, Anmol, for a great presentation. And thank you, Prof. Rez, for the wisdom and the casual shirt. It's inspiring me to be more and more chill at work every day. All right, yo. Bye.
I'm going to come and decorate your face. Bye, everyone.